各位老师、各位同道，下午好。那么，经过上午我们半场的一个学习，我们开启了下午的学习讲座。很高兴呢，担任我们下午上半场的一个环节主持。那么，我今天很隆重的介绍李天照教授的一个讲座。李天照教授是香港中文大学妇产科学系的教授，香港联合生殖医学中心主任，亚太生殖学会的最新主席。李教授对生殖失败有着浓厚的兴趣，并在同行评议的国际期刊上发表了400多篇论文，为中国和英国多所大学的名誉教授。那么李教授今天给我们带来的题目是反复种子失败和复发性流产的免疫因素。李教授呢，这次授课采用录播的形式。那么下面我们欢迎李教授精彩的讲座。
I would like to say that I would not be covering progesterone therapy, although it has immunomodulatory effects. I will also not be covering antiphospholipid syndrome because it is generally classified as a prothrombotic condition, even though the diagnosis involves antibody testing. I plan to cover the following 5 areas. The first is the immunological hypothesis. Second, on recurrent miscarriage. Third, on recurrent implantation failure. Fourthly, the clinical perspective, especially to address the question of whether we should treat or not treat our patient with immunotherapy. And lastly, what is new in the subject. We now know that successful implantation does involve maternal immune adaptation, not only to prevent rejection of the embryo, but also actively facilitate apposition, attachment, and invasion of the embryo. The immunological hypothesis of reproductive failure is an attractive one. It refers to inappropriate maternal immune adaptation resulting in implantation failure and miscarriage, including repeated implantation failure and recurrent miscarriage. I must say that the immunotherapy is so amazingly attractive to patients, as outlined in Dr. Ellen Beer's book, Is Your Body Baby Friendly? As regarding recurrent miscarriage, there are 2 international guidelines published on the subject, both by the RCOG and the ESTRI, and the 2 international bodies both do not recommend testing. NR means not recommended for NK cell number in peripheral blood, NK cell cytotoxicity in peripheral blood, uterine NK cell number, cytokines, cytokine polymorphism, HLA compatibility and subclass, anti-HY immunity, ANA, anti-HLA antibodies. Some of them the RCOG did not refer to, but I think they do cover it in the newer version. Regarding published RCTs on recurrent miscarriage, 3 earlier studies suggest that they might be of benefit in a relatively small number of patients in the randomized controlled trial. However, more recent studies, many of them suggest that immunotherapy do not have any benefit when used in women with recurrent miscarriages, including IVIG, glucocorticoid, intralipid, and GCSF. On the basis of that, both the ESTRI and RCOG would not recommend immunotherapy, including lymphocyte immunization, prednisolone, IVIG, intralipid, GCSF, cyclosporine, and heparin. I know, on the other hand, that there are ongoing RCT on recurrent miscarriage, as outlined in this slide. I would await with interest to see whether the results of the studies, when published, would change our current practice. As for recurrent implantation failure, the biomarker, none has yet been shown to be clinically useful so far. And as for published RCT in recurrent implantation failure, there are several of them, but it is of interest that most of them come from Iran, and most of the papers are published in their local journal only, the Iranian Journal of Reproductive Biomedicine. Now the name has changed to International Journal of Reproductive Biomedicine. The study from Saudi Arabia on intralipid did not show any significant benefit with treatment in women with recurrent implantation failure. Other than this published trial, there are many ongoing trials in recurrent implantation failure, suggesting that it is indeed a very hot topic, drawing a lot of attention from investigators all over the world. The one listed here, the one particular interesting is the one from Shanghai using prednisolone. I say this because it seems to be the one properly powered to answer the question, whereas many of the smaller ones are mostly underpowered. There are also older trials in RCT in recurrent implantation failure. Many of them went back as far as 2007 and 2012, and noticed that even though this RCT has been going on for some time, they have never been published. One might speculate that they have encountered problems in recruiting patients, but it is also recognized that negative RCTs are more likely to be published. So one would view these trials with a bit of skepticism. So mini summary, what we know, we don't know. A reliable immune biomarker which can predict success or failure has not yet been identified. And secondly, an effective immune treatment for recurrent implantation failure or recurrent miscarriage has not yet been found for both recurrent miscarriage and recurrent implantation failure. Next is about the practical question to treat or not to treat our patient with immunotherapy. I guess the majority of you would say no, because they have not been recommended by international societies. There is insufficient evidence of a benefit, and the vast majority of our colleagues do not offer it. And the live birth rate in the case of recurrent miscarriage without treatment is 67 to 70% anyway, so why bother? And it could be argued that honesty is the foundation of clinical practice. And finally, the treatment is not without side effects. As summarized in this slide, it has been reported that lymphocyte immunization may cause infection, possible long-term risk of hematological malignancies, and risk of neonatal autoimmune thrombocytopenia, and may result in erythroblastosis fetalis. Prednisolone has been known to be associated with preterm birth, diabetes, and hypertension. IVIG may cause skin rash, viral infection, and is known to be rather expensive. Intralipid may cause thrombophlebitis, allergic reaction rarely resulting in acute kidney and lung injury, cardiac arrest, headache, dizziness, flushing, drowsiness, and sweating. GCSF may also cause dyspnea, chest pain, and hypoxemia. I know some of you may say, yes, I do want to offer it because my experience suggests it probably works, and that you might say absence of evidence of benefit does not necessarily imply evidence of no benefit. One might think it is better than nothing, that the patient wants it, feels better with it, why not? Moreover, the hospital may be happy for me to do it. I think the answer is in a fine balance between clinical freedom and responsible practice. And when the fine balance can be made, it should lead to progress. So looking back at the international guideline regarding treatment, the recommendation is that not to offer them unless in the context of research. In other words, you could offer the treatment, yes, you can, but you should do it in the context of research. It could be a randomized controlled trial or well-planned cohort study. You should ensure that the patient are properly informed, especially the absence of benefit, absence of evidence of benefit, not to raise false expectation or hope in a desperate patient. You should endeavor to collect essential clinical data and analyze them regularly, and be prepared to share the data with your colleagues. And finally, you should try also to add new knowledge to the literature. Finally, what is new in the subject? 2 years ago, the Nobel Prize for Medicine 2018 was awarded for cancer immunotherapy based on the inhibition of negative immune regulation, especially the PD-1 pathway. The question is whether or not the trophoblast also escaped the immunosurveillance using similar pathway. We now know that immunomodulation of normal pregnancy does appear to involve the PD-1, PD-L1 pathway, because the trophoblast expresses the ligand PD-L1, and when this ligand is bound to its receptor PD-1 in T cells, it offers protection against T cell cytotoxicity. The Shanghai group also demonstrated that the trophoblast also utilizes another pathway, the TIM3 and galectin-9 pathway. The trophoblast expresses galectin-9, a ligand for TIM3, which is immune checkpoint on a subset of peripheral NK cells, which modulates maternal immune response to prevent fetal rejection. And they further shown that miscarriages associated with reduction of TIM3 expression in peripheral NK cells. The limitation of current literature data are that most studies focus on immunomodulation after pregnancy has been confirmed. In other words, implantation process is well established. But there is very little information on immunomodulation at the very beginning of the implantation process, that is immediately upon the arrival of the embryo. So we in CUHK recently conducted an implantation study. The objective was to investigate changes in peripheral lymphocyte subsets ratio and function during the first few days of implantation, with a special reference to the TIM3 and PD-1 expression. Our hypothesis being that successful implantation is associated with alteration in the ratio of peripheral lymphocyte subsets and the TIM3 and PD-1 expression immediately after blastocyst transfer. The study design is one of prospective, longitudinal, observational, and clinical study. The subjects are recruited from the ALT unit of the Prince of Wales Hospital, Chinese University of Hong Kong, between November 2018 and August 2019. They all underwent an IVF treatment and the embryo transfer. The inclusion criteria include women having 1 or 2 blastocysts transferred in fresh or frozen cycles at the age between 20 to 40 years. And there's a list of exclusion criteria including hydrosalpinx, structural anomalies, antiphospholipid syndrome, abnormal thyroid function, polycystic ovary, hormonal or metabolic disorders, known clinical autoimmune disease, undergoing immunotherapy, cancer post-cancer status, and finally, any significant medical complications. In all these subjects, blood samples were taken at 4 specified time points. For the date of embryo transfer as day +0, then 3 days later and day +3, day +6, and day +9. The blood sample at these 4 time points correspond to the events in implantation as follows. On day plus naught, it refers to arrival of the embryo into the uterine cavity and the commencement of the implantation process, namely attachment. Then 3 days later, on day +3, by that time, embryo has just migrated across the luminal epithelium and begins invasion into decidua stroma. Day +6, the trophoblast has already invaded into the deeper stroma associated with marked decidual immune cell response and angiogenesis. And then on day +9, patient are routinely back to the clinic for a blood test sample to measure HCG to find out if they're pregnant or not. So we use flow cytometry to measure the lymphocyte subsets. For NK cells, there are 3 subsets of NK cells, T cells, 2 subsets, and NK-like T cells. We also measure the TIM3 and PD-1 in lymphocyte subsets. We also employ ELISA to measure the ligands PD-L1 and galectin-9. As for the results, we eventually recruited 18 subjects who didn't conceive after blastocyst transfer, and 33 women who conceived with ongoing pregnancy after 12 weeks. But we have excluded 8 subjects who conceived but miscarried. So the results set number 1 is the percentage of peripheral NK cells. In this slide, you'll see on the vertical axis the percentage of the immune cells. In the horizontal axis, you'll see the timeline, time points after ET, day 0, day 3, day 6, and day 9. And the violet bar refers to those who are not pregnant, whereas the blue bar refers to those who are pregnant. There are 2 striking observations in this, which is similar for all the 3 subsets of NK cell. The first is there is no difference between the 2 groups of subjects who did or did not conceive. And secondly, there is no change in the proportion, in the percentage of the various subsets across the various time points. The same applies to the percentage of peripheral T cells, whether it's CD3 plus, CD8 plus, or CD4 plus T cells. Again, no difference between those who did or did not conceive, and no difference across the various time points. Finally, as regards the percentage of peripheral NK-like T cells, similar observations, no difference between those who did and did not conceive, and no change throughout the various time points. So the conclusion for this part of the study is that the proportions of lymphocyte subset did not alter at any of the time points, and there was no significant difference in the result between women who did or did not conceive for all the time points. So from that, one can say that the measurement is of little clinical value. The second set of results refers to TIM3 expression in the various lymphocyte subsets. The first, as shown in this figure, is the NK cells. Comparison between women who did and did not conceive. So the blue line refers to women who conceived, whereas the orange line refers to women who didn't conceive. And on the panel A, refer to CD56 dim cells, whereas the panel B refers to CD56 bright cells. First of all, going to panel A, you'll see that in women who conceive, there is a significant drop in the expression of NK cells, TIM3 expression in NK cells on day 3 and day 6, which appear to return back to normal by day 9. Whereas there is no such phenomenon in those who did not conceive. And the difference between the 2 groups was significant on day 3 and day 6, but not on day 0 and on day 9. The change is not so obvious, referring to CD56 bright cells as in panel B. TIM4 expression in T cells in women who did and did not conceive are remarkably similar to the NK cells in that there was a significant drop of the expression in women who conceived and returned back to normal by day 9. Panel C refers to CD8 positive T cells, whereas panel D refers to CD4 positive T cells. And there was a significant difference you can see between the two groups of subjects on day 3 and day 6, but not on day 9, nor on day 0. Again, a remarkable similarity in the pattern of TIM4 expression in NK-like T cells on this occasion. Significant drop on day 3 and day 6 and back to normal on day 9, and being a significant difference between the two groups on days 3 and 6, but not on other days. So the conclusion in this part of the study is that there was no significant difference in baseline TIM4 expression between women who did and did not conceive. Whereas among women who conceived, there was an instant, transient, and significant reduction of TIM4 expression on the surface of peripheral NK cells, T cell, and NK-like T cells on days 3 and 6 only after ET, which returned back to baseline level by day 9 after ET. The change in women who did not conceive appeared in an opposite direction. As regard rather negative result relating to PD-1 and the ligand galectin-9 and PD-L1, for those of you who are interested, may refer to our publication in Fertility and Sterility a few months ago. We have recently extended our study to find out if cytokine profile may be alternative immune markers. So we retrieve the stored blood samples and measure cytokine profile using multiplex microsphere-based cytometric assay, and also using ELISA to measure TGF-beta1 in addition. So here are the results regarding pro-inflammatory cytokine in women who did and did not conceive. In the left-hand panel refers to interferon gamma, and the right-hand panel refers to interleukin-17. And you will see in women who conceived, as in the blue line, there was an instant increase in the pro-inflammatory cytokine on day 3. The same applied to those who didn't conceive as well. But among people who conceive, there was a drop of the pro-inflammatory cytokine back to normal on day 6 and day 9, whereas in women who did not conceive, the increase in pro-inflammatory cytokine appeared to be sustained. They come and refer both for interferon gamma and interleukin-17. On the other hand, regarding anti-inflammatory cytokines, as in the case of TGF-beta1 and IL-10, in women who conceive, as in the blue line, you see there is a sustained, steady increase in the anti-inflammatory cytokines. On the other hand, in women who did not conceive, there does not appear to be an increase, but for the IL-10, as in the right-hand panel, there was a steady reduction in anti-inflammatory cytokine instead. And there was a significant drop, and there also appeared to be significant difference between the two groups of subjects as regarding interleukin-10 on day 6 and day 9. If you express the results in cytokine ratios in women, comparing them between women who did and did not conceive, the pro and anti-inflammatory cytokine ratio, which has been used frequently in the literature. So you'll see a more striking difference between the two groups. So on the left-hand panel is the interferon gamma over interleukin-10, a very marked divergence of results. One goes up steadily in a patient who didn't conceive, whereas in a patient who conceived, it dropped down steadily. The same applied to the right-hand panel for TNF-alpha over IL-10. The marked divergence in results suggests that change in ratio observed in early pregnancy may be a good diagnostic immune marker. So conclusion regarding this study is that among women who conceived, there was an early, instant, transient, and significant increase of pro-inflammatory cytokines, interferon gamma, IL-17 on day 3, which returned back to baseline on day 6 after ET, and that there was a second phase of increase of anti-inflammatory cytokine IL-10 from day 6 to day 9 after ET. So the conclusion number 2 is that in women who did not conceive, there was, on the other hand, a more pronounced pro-inflammatory cytokine change, which did not manage to switch to an anti-inflammatory profile. And there was no significant difference in baseline between those who did and did not conceive. So for those of you who are interested in the details of our study, may refer to our publication online in Fertility and Sterility. In another study, we attempt to analyze the relationship between uterine NK cell and chronic endometritis. What we found in this study was that women who have high NK cells are more likely to have chronic endometritis, and also among women who have chronic endometritis, they are more likely to have a high UNK cell. So the clinical implication of this study is that appropriate treatment for putative immunological cause of reproductive failure really should involve and depend on finding underlying cause. As an example of chronic endometritis and UNK cell, if the UNK cell increases due to underlying chronic endometritis, it ought to be treated with antibiotic and not immunomodulatory agents such as steroid. I mean, the same principle should apply to other potential causes of altered immune cell profile, including allergy, hormones, environmental toxin, and stress. I'd like to mention specifically the impact of progesterone because it is well known to have immunomodulatory effects. So finally, summary, I must say that reproductive immunology is a fascinating subject. It is a very hot topic, attracting a lot of interest, but it also is a very controversial issue. At present, there is insufficient evidence to support routine immunological testing or treatment. A fine balance ought to be made between clinical freedom and responsible practice. It doesn't mean that we can't treat our patient or investigate, but it ought to be conducted in the context of a clinical trial. Immune biomarkers are more informative if they're sampled after arrival of the embryo to uterine cavity. They are much less informative if they are performed prior to conception. Finally, a search for the underlying cause of an abnormal immunological test result should be made, such as infection, allergy, endocrine, or other disorders. Finally, I must acknowledge the help of my colleagues, many of them for their help in conducting the clinical trial and also for the help in preparing this lecture. And finally, I would like to also thank you all for your time and attention.